Good afternoon, and welcome to Wellspring Presents, a health and wellness forum presented in part by the Berean Seventh-day Adventist Church, the Niles, Philadelphia, and All Nations Seventh-day Adventist Churches. Our topic today is women's health. This is Women's History Month, March that is, and we want to engage in this celebration with you by sharing ways to embrace a healthy lifestyle as a woman. We have a panel of 3 experts, and we'll be discussing various steps you can take to prevent chronic diseases, as well as sharing ways that you can live your best life through multiple sclerosis, heart disease, or cancer. And with heart disease and cancer being the leading causes of death among women ages 15 to 34 in the United States, it's crucial that we make ourselves aware of the importance of heart health and an overall healthy lifestyle. Taking steps toward a healthy lifestyle early on lowers our risks of such diseases. This is a really personal topic for me, as my mom suffered from heart disease and hypertension and actually passed away from stroke-related illnesses. So I think it's important for me, and I'm sure for many of you, to understand what we can and should be doing to take care of ourselves. In my family, the women in the family just did what they had to do. And taking care of themselves was kind of at the bottom of the list. They took care of others first. They took care of their children. They took care of their husbands. They took care of their church family. But taking care of themselves was at the bottom of the list. And that allowed, and especially in the case of my mom, as I'm thinking today, for high blood pressure to go untreated and for stroke and heart-related issues to go undiagnosed. And so today I think it's important that we take the time to focus on what our health is and we take care of ourselves. Because when we take care of ourselves, we can take care of the others around us. And God has blessed us today with 3 very talented women who are going to provide a lot of information for us. So today we're going to be focusing on celebrating women and their roles in the world, identifying health challenges for women specifically, providing some facts on women's health, and then also providing tips to prevent disease, reverse disease, and manage it, and also restore health. Each one of our panelists will share a short presentation on the topic, and the remaining time we're going to be devoted to question and answers. So as you're listening to the presentations, please take a moment to jot down a question, type that into the chat, and we'll be addressing all those questions at the end. So right now I'm going to introduce our first panelist, which is Marie LeGrand. She is a Senior Director of Mission Delivery and Health Equity for the Multiple Sclerosis Association of America. She's got a background in public health, 10 years of experience in disease prevention, health promotion, health policy, and population medicine. She's responsible for program administration and implementing strategic oversight of the MSAA's patient and provider programming, overseeing health equity initiatives, and developing multifaceted interventions for the MS community. She serves as a co-chair for the African American Advisory Board at the MSAA and recently published a white paper on MS and the African American experience. Additionally, she has led policy and advocacy efforts federally and within state policy strategies and has served in roles that have advanced the human rights of marginalized communities, providing wraparound services to the African American, Latinx, and LGBT communities. Marie, thank you so much for joining us today. We are so happy to have you. That's quite a bio. God has certainly blessed you, and I know you put in a lot of hard work. So thank you so much for being here, and please talk to us about multiple sclerosis and what we can do to take care of ourselves.
Well, thank you so much, Debbie. I'm so honored and so happy to be here. So thank you so much for having me. I am really excited to talk about an area that I am extremely passionate about. And considering that this is also Women's History Month, as well as MS Awareness Month, I'm happy to have the opportunity to talk about both with a specific focus on the Black community, as well as the Hispanic and Latinx community. So I'm just sharing my disclaimer. All right, let's get right into it. So What is MS? Multiple sclerosis, which is also known as MS, is considered to be an autoimmune disease in which the body's immune system attacks its own tissues. And so the immune system malfunction destroys the fatty substance that coats and protects nerve fibers in the brain as well as the spinal cord called the myelin. And the myelin is similar to the coating around an electrical wire, to give you an example. And I do have a picture just to show you the difference between a normal nerve and the nerve of someone who's living with MS. And so the damage to the protective covering and also to the nerves disrupts the smooth flow of nerve impulses. And as a result, messages from the brain and the spinal cord going to other parts of the body may be delayed and have trouble reaching their destination, which causes the symptoms of MS, which we'll get into shortly. So now MS is an unpredictable disorder, and it can cause a variety of symptoms and can cause flare-ups. There are periods where those will recede for some days, months, or even years. So let's talk about the earliest documentation of MS. So possibly the earliest documentation of multiple sclerosis is in the case of an individual, a young woman by the name of Ludwina, who lived in Holland around the early 1300s. However, MS received its official name in 1868 from neurologist Jean-Martin Charcot. So some of the common symptoms that are associated with MS varies greatly, and it varies from person to person. So just because one person is necessarily living with a certain symptom does not automatically mean that it's going to be the same in someone else. Okay. So these symptoms may possibly affect a person's physical, emotional, mental, psychological well-being, including others that cannot be seen, which are known as invisible symptoms of MS. So the types and severity of MS, as I mentioned earlier, it varies greatly between people from person to person. So one person's experience will not be the same as another. So I'll talk about some of the common physical symptoms that we generally see, which includes balance problems, and those are physical symptoms. So there are balance problems, bladder dysfunction, bowel problems, mobility and walking issues, sexual dysfunction, spasticity, which is stiffness. You will also have some individuals who will have speech difficulties, swallowing disorders, as well as tremors. Now, we do have other symptoms that fall under emotional, mental, and psychological, such as anxiety, cognitive changes, depression, as I mentioned earlier, invisible symptoms, which are known as dizziness, vertigo, fatigue, numbness, and visual disorders, just to name a few. So, contrary to what some may believe, MS is not contagious. And so now, while MS is not contagious or hereditary, there is a likelihood that if a family member has MS, researchers, most likely that individual will. And so researchers are still searching for answers on how MS is developed, as well as what treatments will be the most effective for people living with MS. There are currently a number of long term treatments known as disease modifying therapies or DMTs, and they're available for the majority of individuals with MS. And though these treatments do not cure MS, they do work to slow down the disease activity as well as delay progression. So, additional treatment options are also available to reduce the severity of a relapse as well as to address the various symptoms of MS. So let's get into who it affects. So MS affects all races and ethnicities. According to recent estimates by the MS Society, approximately 1 million people in the US are living with MS. And though this disease is predominant among white people, specifically those of Northern European descent, MS does affect all races and ethnicities, as we're finding out. Now, some population may bear a disproportionate share of the disease burden. There is also growing evidence showing that persons of color are equally affected by MS and may carry more disease severity. as well as earlier progression. Specifically, recent research suggests that Black Americans carry a higher risk of developing MS and appear to experience a particularly aggressive disease course with increased severity and more rapid progression. Additionally, there are clinical differences in existing symptoms when comparing Hispanic adults with MS to non-Hispanic whites with MS. So, MS is considered a young person's disease. And though individuals of any age may be diagnosed with MS, most people experience their first symptoms and are diagnosed between the ages of 15 and 50. More women are affected, 3 to 4 times more so than men. And we're not entirely sure why, but researchers, there are studies that suggest that female hormones may play a role. Additionally, there is no evidence that MS impair fertility or leads to miscarriage. And relapses do decrease during pregnancy, but do increase after delivery and then decrease a few months afterwards. Most medications used to treat the symptoms of MS are not safe to use during pregnancy. So, we highly recommend for any person who is planning to become pregnant or who is to please speak with your doctor, your healthcare provider. All right, let's talk a bit about racial and ethnic health disparities in MS. So, social determinants of health, okay, in MS, but specifically social determinants of health refers to the conditions that people are either born into, grow in, where they live, where they work, and their age. There are factors such as socioeconomic status, education, your neighborhood, physical environment, employment, and social support networks, as well as access to health care, which all define the social determinants of health. And that greatly impacts a person's quality of life. There is a lack of trust in the medical system and physicians among communities of color. And that creates a barrier to care as well as a lack of research participation, which is extremely important when we're considering treatment for racial and ethnic groups. So socioeconomic can affect the quality of care that a person living with MS receives, which leads to poor health outcomes. And so, in addition, researchers and healthcare providers must also acknowledge the roles that they play in the continuation of health disparities and find ways in which to reduce mistrust and increase research participation. So, race and ethnicities are determinant factors in the quality of care that is received. So, health disparities, which are defined as specific differences in health that are closely linked with social, economic, and/or environmental disadvantages. And unfortunately, health disparities has systemically affected race and ethnic groups far more frequently than we would like to believe. Quality of care has often been based on race and ethnicity and historically linked to discrimination, regardless of your class. So, whether it is a person of color who is from the working class or from what many would consider a high class, the disparities are about the same. And so persons of color do bear a disproportionate burden of disease, quality of life, and reduced life expectancy, which can also produce a loss of income. And so when we talk about health disparities also have an effect on our society as a whole. So it's not just the individual that it has an effect on, it has an effect on our society, our country. And some of that include increased healthcare costs, low productivity. It's estimated that by 2050, racial and ethnic groups will account for nearly 50% of the total US population, which is why it is so important and so imperative that we work together to decrease health disparities as well as other racist practices. And so, for many health conditions, Black Americans bear a disproportionate burden of disease, as many may be aware, injury, death, and disability. According to an article in the American Journal of Public Health entitled Black White Health Disparities in the US and Chicago, a 15-year progress analysis, disparities in mortality resulting from conditions including heart disease, cancer, and diabetes between Black Americans and white Americans not only exist but have grown increasingly wider. And so, though strides have been made, we are still far from eliminating racial and ethnic health disparities and achieving health equities. This is why it is, again, as I mentioned, it is so imperative that we do address the elephant in the room and work together to fix these issues. Women are 3 to 4 times more likely than men to develop relapsing forms of MS, as I mentioned. And so, in addition, employment is an issue for women with MS, which is significant given the high rate of divorce for MS patients. So historically, people living with MS were told that they should quit working and or avoid telling their employer of their diagnosis because employers would use that against them. And though it is an individual choice, it can be extremely difficult for many to continue working. There are outstanding needs to be addressed for women with MS, including financial security, which can lead to poor health outcomes and decreased quality of life. And apart from low representation in research and clinical trials, Black and Hispanic and Latinx people with MS have higher morbidity and mortality. We should also talk about the lack of trust in doctors and medical system, which is all part of racial and ethnic health disparities in MS. And while we're learning that MS disease progression can vary in minority groups and that differences in cultural norms and health system impact it as well, without the participation of these populations in research studies, it does become impossible to truly understand how the disease manifests and which treatments will work best in all persons with MS. Because believe it or not, there are certain treatments, certain disease modifying therapies that will not work for people of color. However, many are fearful of medical research and clinical trials due to historical events such as the Tuskegee syphilis study and other unethical research and discriminatory practices in healthcare. So let's get more into the specifics of Black women in MS. So, Black Americans may have a more aggressive course of MS. And though it was once widely accepted statements that Blacks had a lower risk of MS than whites, findings published over the past decade tells us a different story. So, the commonly held misconception of lower risk in African Americans is likely the result of a lack of research specific to minority populations, and this assumption based on worldwide prevalence of MS in different regional and racial and ethnic demographics. So, for example, in the continent of Africa, you will not see many cases of MS among Black people. Black Americans tend to have more symptoms at the time of diagnosis, which are usually limited to the optic nerves and spinal cord. And this is termed as optical spinal MS, which means that Black Americans may experience more problems with vision and mobility versus other common MS symptoms that I mentioned earlier. And the disease course tends to be more progressive and responds less to disease modifying therapies. Black Americans may also have a more aggressive course of MS and often experience disparities in diagnosis and treatment, as mentioned earlier. Some literature do suggest that Black people living with MS may have difficulty walking or walking disability, and their MS may progress earlier. Again, there is limited research to determine the reason why. So, when we talk about risk being highest for Black American women, we're talking about disease related disability at diagnosis, which is significantly more severe in women. Now, in one study, the risk of Black women being diagnosed with MS went over 40%. There are many doctors outside of MS who are not aware of emerging data that is coming out on the growing number of racial and ethnic groups who are being diagnosed with MS. And though many people are getting diagnosed early on due to modern medicine, thankfully, There are still many persons of color, specifically Black women, who are being diagnosed far later, resulting in delayed treatment, which can bring on more frequent relapses, earlier signs of disabilities, and disease progression. So, some of the reasons for delayed treatment and also misdiagnosis would be this misconception that it's a white person's disease. And though that was the prognosis many years ago, decades ago, um, we are now seeing a different picture being painted. There are many who felt that their diagnosis was delayed because doctors initially believed they had other conditions that are often found in Black people, such as lupus, sickle cell disease, fatigue, stress, Parkinson's, and stroke. Some studies have also found that Black American patients were less likely to be seen and treated by a neurologist that specializes in MS. So, during some of the meetings that I've had personally, there were a few who shared their stories on how they were misdiagnosed for many years until they were able to meet someone, specifically a Black neurologist, who was able to make that diagnosis. That is a major issue considering the importance of treatment. MS in Black Americans is a unique experience compared to a white person living with MS, and for many reasons, including genetics and sociocultural factors. Now, let's talk a bit about Hispanic and Latinx women in progression in MS disease. Um, so, though MS is not as common in the Hispanic and Latinx community, the number of individuals being diagnosed is increasing here in the US, and the impact of MS is also detrimental. Research shows that Hispanic and Latinx people who have lived in the US for a longer time or those born here may have a greater risk of developing MS and at an earlier age. So, we are in need of more research to determine why and how vitamin D deficiency plays a role in impacting MS risk. Similar to Black Americans, Hispanic Americans are more likely to also have a vitamin D deficiency. Hispanic and Latinx Americans often are diagnosed at an earlier age than Caucasian Americans. They are more likely to also have optical spinal MS, optic neuritis, which is the inflammation along the optic nerve. And as well as transverse myelitis, which is inflammation of the spinal cord. And that's the part of the central nervous system that sends impulses from the brain to the nerves in the body. So, the prevalence of MS in the Hispanic and Latinx community is expected to rise. So, the disparity in acknowledging the unique experiences in MS journey in diverse groups of individuals, such as Hispanic and Latinx people, has resulted in marginalized communities and gaps in care within the MS space. We are in need of a deeper understanding of how an MS diagnosis can impact people based on biological and socioeconomic factors, and has uncovered clinical differences in existing symptoms when comparing Hispanic adults with MS to non Hispanic whites with MS. So, the Hispanic and Latinx MS community continue to be underrepresented in clinical trials as well. And they do face barriers to early and accurate diagnosis, as well as access to quality care and treatments compared to their white MS patients. Again, similar to Blacks living with MS, many consider this to be a white person's disease. And so the perception of MS can also play a role in how some Hispanic and Latinx individuals determine care, affecting disease management as well as patient engagement. While doctors and experts work to evolve deeper scientific understanding of MS in Hispanic patients, it is crucial for the underserved Hispanic and Latinx MS community to have the opportunity for targeted education from specialists who are a reflection of them and providers who have an understanding of the cultural, religious, and socioeconomic influences that may be guiding the types of treatments that individuals are seeking. So, according to the U.S. Department of Health and Human Services, Office of Minority Health, the Hispanic community suffers significant barriers that can impact health. And some of those include language, a lack of insurance, and access to preventive care, cultural variances, undocumented immigrants, and other elements such as healthcare costs for treatment. When we talk about understanding MS as a family, we're talking about having a discussion with your loved ones. It's important to discuss MS with your loved ones. Following an MS diagnosis, many may feel isolated, withdrawn, angry, sad, and feel a loss of identity. So, speaking to a family and marriage therapist may be essential and may be able to provide some guidance for the person living with MS as well as their loved ones. Another thing to consider is the care partner role. So, a care partner can be a parent, it can be a child, sibling, significant other, relative, or friend. According to a study in Outcomes and Insights on Health Management, about 52 million caregivers provide care to adults and with a disability or illness, with a sizable percentage of those caring for patients living with MS. And the effects on the average family member who do perform caretaking duties are profound. About 70% of working caregivers have incurred work related difficulties due to their dual roles, and 69% have reported having to take unpaid leave or less hours at work due to the responsibility of caretaking. And apart from financing, the physical health of the care partner is also of concern. About 11% of care partners have that. Reported that due to their increased responsibilities, their health has deteriorated. And that's something you have to think about. And 21% of older care partners have reported a higher degree of physical strain, particularly those who are over the age of 65. So it is imperative that care partners do find support services, and there are many that are available to provide assistance to both the person living with MS as well as the care partner. As mentioned, there are a number of organizations that can be a good resource to the MS community and their families, and I'll share some of those towards the end. It's important to communicate with children and teens. So, oftentimes, children and teens are not considered in the care team process. And the experience of children either living with MS or living with parents who have MS is a significantly underserved and understudied population. A lack of communication can contribute to misunderstandings of MS, fears, anger, feelings of seclusion. And while the understanding of an MS diagnosis is different for every family member, it is important to keep the lines of communication open and allow for children and teens to contribute to a discussion around MS. It's important for them to ask questions as well as allow them to be advocates for themselves and their loved ones with MS. Now, let's talk a bit about what's on the horizon. As I mentioned earlier, we're now seeing more research being conducted among persons of color living with MS, specifically Black men and women living with MS, as well as Hispanic and Latinx men and women living with MS. And so we're seeing more research that's being conducted, and that's to gain a better understanding of how MS affect racial and ethnic groups. So we have a few organizations that do provide information in those areas. So the National African Americans with MS Registry was in part created to gain a better understanding of the number of African Americans diagnosed with MS in the US, and those living with MS are encouraged to learn more. We also have the CHIME study developed with patients as well as advocacy groups and clinical researchers. We have the clinicaltrials.gov, which is a database of clinical studies from around the world that people can look into. Um, Nextly, we have disease modifying therapies. So there are more than 20 approved brand name and generic DMTs that are available. So we highly recommend for any persons living with MS to speak with your doctor, your neurologist, your MS specialist, to be more specific, to find the right one for you. Some individuals also choose, in addition to being on a disease modifying therapy, they choose complementary and alternative medicine. Yoga is a great form of stress reliever as well as exercise, acupuncture, Tai Chi, guided imagery, and there are many more. Physical therapy and occupational therapy is also essential and can really help in day to day practices for individuals living with MS. So, living healthy with MS. When we think about living healthy with MS, we think about nutrition, exercise, stress management, and comprehensive care. So, it's important to eat healthy. It's important to not necessarily focus on a diet plan, because when we think about diet, we often think about something that is temporary. So you want to look at nutrition more as a healthy lifestyle, something that will carry you through life. So eating healthy, and if need be, you can employ the services of a nutritionist to provide you with the plan that's best for you. Exercise. It's important to stay active at your own pace. So, one person's exercise will not necessarily be the same for someone else. So, determine what's best for you. But it's important to exercise, it's important to stay active. But more importantly, it's important that you do activities that you find enjoyable. Stress management. Chronic diseases, people living with chronic diseases, it can be extremely stressful on the person and their loved ones. So it's important to reduce stress. And if needed, work with a mental health therapist, a counselor, someone who can provide you with guidance, a professional that can provide you with guidance to help decrease your stress levels. And then find things that you enjoy doing, whether it's going for a walk, spending time with loved ones, going to the movies, traveling, whatever it is, find ways to reduce your stress. And if it does get to be too burdensome, again, speak with a professional, a mental health therapist who can provide you with some guidance, some tips, and some suggestions to decrease the stress levels. Comprehensive care. So we are a whole body. And though there are certain chronic conditions that will be at the forefront, you have to remember there are other aspects of your body that also need care. So you have a healthcare team that includes your primary care provider, your OBGYN, and any other healthcare provider that will provide you with the best of care. As mentioned, sometimes other conditions do take a back seat to chronic diseases such as MS. So it's important to remember that, again, you are a whole person, and the whole body needs to be treated and cared for. Then you have patient self advocacy. You are your best advocate. So always ask questions when you don't understand and educate yourself. There are many organizations, such as my organization, MSAA, that offer free educational programs to members of the MS community and their families and friends. One suggestion is to write down or have a loved one write a list of questions and items that you would like to discuss with your healthcare provider at your next appointment. So if you don't feel comfortable advocating for yourself, or if you cannot, that's perfectly fine. Again, there are organizations that can help, or you can also find someone that you trust who can advocate on your behalf. So these are some of the resources. So again, within my organization, we are a national nonprofit organization, and we do provide free services, including a national helpline. We have equipment and cooling products, MRI funding, an online community, webinars, and many more free programs available to people living with MS all across the country. And you can always visit our website to learn more. Additionally, we have a few more resources. So we have another organization, We Are Ill, which is a nonprofit organization with a mission to redefine what sick looks like for Black women living with MS. And they not only help in improving the overall health outcomes for Black women living with MS, but also eradicating the disease. And they offer a variety of services and information around diversity in clinical trials, patient advocacy, community, and many more. We also have the Accelerated Cure Project for MS. And so within the Accelerated Cure Project for MS, we have the MS Minority Research Engagement Partnership Network. And that is a multi stakeholder network that has come together to define and address the issues of racial and ethnic minority representation in MS research. We also have the National MS Society and the Multiple Sclerosis Foundation. And again, there are many other foundations that are out there providing services for people living with chronic conditions such as MS and disabilities. So, as I mentioned earlier during the talk, MS is also, apart from Women's History Month, it's MS Awareness Month. And so, we at my organization, we're proud to support MS Awareness Month during the month of March. And we're offering several online educational activities, including podcasts. We have 2 podcast episodes, 2 webinars featuring experts in the field of MS. So, if anyone's interested, you're more than welcome to learn more. And lastly, I'd like to leave you with this: staying positive with MS. Now, I know it can be easier said than done, so I will leave you with 2 quotes. Every day may not be good, but there is something good in every day. When we think about living with a chronic condition, it can be extremely stressful. And so that is one of the reasons why I really love that quote. Every day may not be good, but there is something good in every day. And then lastly, another quote by Christopher Reeve is: when the unthinkable happens, the lighthouse is hope. Once we choose hope, everything is possible. Thank you so much for having me, and I'll turn it back to you, Debbie.
Great information. I do have some questions for you, and I know we will have some of our viewers with questions as well that we'll have at the end. So thank you so much, Marie. We'll be back with you after the end of the other presentations with some questions. Thank you. Our next presenter is Dr. Christelle Mio. Dr. Mio hails from the Caribbean island of Haiti, where she spent the early years of her life. She did her undergrad at Andrews University and medical school at Loma Linda University in Loma Linda, California. She's currently working on a fellowship in allergy and immunology in St. Louis, Missouri. And she is going to talk with us about health issues and heart disease. And I will be listening quite closely with my ears wide open. Thank you so much for joining us, Dr. Mio. Please, we're here listening and ready to go. Thank you.
All right. Well, thank you for having me. Let's see if we can get started, and we'll talk about cardiovascular health today. All right. So just a brief overview of what we're going to be talking about. So I'm just going to be covering the background of what we're going to be talking about today. We'll briefly touch on some epidemiology, basically a little bit of numbers, some statistics about how many people we have suffering of this disease. We'll talk about the signs and symptoms, things to watch out for, and mainly we'll kind of cover prevention of this disease and how do we treat it. All right, so what is cardiovascular disease and what is cardiovascular health? So the American Heart Association, or the AHA, it defines cardiovascular disease as whenever blood flow or whenever we have oxygen and nutrients, the flow is restricted or reduced to a part of the body. And so the cardiovascular system comprises of the heart and the vessels and anywhere something goes wrong in that part, we have cardiovascular disease. And so we have ischemic versus hypertensive heart disease. So in ischemic heart disease, that is basically a heart attack, where we have blockage into one of the arteries and blood flow does not go to the heart tissues and the heart does not function. And sometimes hypertension also can affect the pump, that is the heart. And heart failure is also when the pump doesn't work as well. Either the pump is not able to relax as well or is not able to push blood forward to the proper tissues, and we have heart failure. We also have peripheral artery disease, which is basically the same thing as a heart attack, but it can happen elsewhere in the body. And that can be something like in a leg or an arm. Usually, we see it oftentimes in the legs, in the lower parts of the body. We also have strokes, which is the same idea, but it happens in the brain and can be very debilitating. And sometimes small vessel disease, basically the small vessels that accompany nerves, that are in the kidneys, that are in very important body tissues, can also be considered cardiovascular disease. And they share some of the same risk factors, which we will talk about. The evidence, we always talk about evidence-based medicine. And so the evidence is based on large population studies. And so some of the things we'll be talking about today will be basically extrapolated from large population studies that have been done over several years. And that is where we get our data from. All right, these are some examples of what cardiovascular disease look like. On the left side, we have a heart attack where we have blockage of the coronary arteries and we are not able to have proper blood flow to the tissues of the heart. And we have dead heart muscle. The heart is not able to pump as well. And that is where we have some of the symptoms, which we will talk about later. And we have a heart attack. On the right side, we have hypertensive heart disease, where we have an example of a normal heart, and we also have what we call hypertrophic cardiomyopathy, where after years and years and years of untreated high blood pressure, the heart gets remodeled, it gets adjusted to make up for all that high blood pressure, and that in itself can affect the heart, and the heart does not work as well. And on the left, we have an ischemic stroke. Also same idea where we have blockage in one of the arteries and we are not able to have proper blood flow into the brain, and that causes a stroke. And on the right, we have the peripheral artery disease where we also have decreased blood flow into one of the lower legs. And this is to briefly touch on small vessel disease. And so these are some of the things that share the same risk factors as cardiovascular disease. And so it can also cause dementia. We also have chronic kidney disease. We have heart disease. We have retinopathy, which is basically when the eyes are affected. And so there's different body tissues, very important body tissues that can be affected as well. Now, how does one get to the point where one has to worry about cardiovascular disease? There are some risk factors that cause cardiovascular disease, and in women in particular, there are some very specific risk factors that are significant, more so than in men, and we will be pointing those out. We talk about non-modifiable versus modifiable risk factors. So the non-modifiable risk factors are things that you essentially can't do anything about. They are genetics, things that are inherited from your father or your mother via genes, things that tend to run in the family. And we also talk about epigenetics, which is basically how those genes are affected by life events, either before you were born or during childhood, things that you don't necessarily have any control over. And also sometimes upbringing as well, life events, things that are non-modifiable. Things that are modifiable are things that you can modify and change. So things like lifestyle, diet, managing your anxiety and stress. So these are some of the things that we can definitely work on and change. We also talk about traditional versus new and emerging risk factors. So the traditional risk factors are risk factors that have been studied over the past few decades. They are established. There's been very good studies done on those. But there's also some new risk factors, things that we are learning more about recently. That are recognized to be associated with cardiovascular disease. So some of the traditional ones we can see here are smoking, diabetes, obesity, lack of exercise, hypertension and cholesterol, versus the new risk factors that we're noticing more and more, and specifically in women, are pregnancy, autoimmune disease is playing a very big role, and also depression and anxiety. Now, focusing on a little bit on epidemiology, we'll talk about the top 10 leading causes of death in general, the preventable causes of death, and the top 10 leading causes of death in women of color. So I'm going to be throwing some numbers to kind of try to make my point. Here, we have the top 10 leading causes of death by age group in the United States. So this is some of the latest data from the CDC from 2018. So starting from age 5 and up to 65, we can see that heart disease is slowly uptrending. And we know that our population is getting older. And so starting from there, I know that you can see it from the screen, all the way up to 65, we see that the trend is getting higher and higher, all the way to 45 to 54, 55 to 64, and then 65 plus, heart disease becomes second to top leading cause of death. And adjusting also for the aging population, we can see that the heart disease is still leading. And here we have the number of potentially preventable deaths. Also, diseases of the heart is still leading. We can see from 2010 to 2014, there was a slight decrease. And unfortunately, that decrease is less for women than men, and even less so for African-American women than white women. And here we can see in all races and origins, females of all ages, heart disease is the leading cause. Now, about 35% of women in the United States will have some form of cardiovascular disease. Now, also for men, the number is actually higher. The number for men is 37.6%. So about 1 in 3 women in the United States will have some form of cardiovascular disease. And here we can see the breakdown by race and ages. So we have, in general, the numbers stays pretty high. We have non-Hispanic white women at 22%, Black women at 23%, non-Hispanic American Indian or Alaskan Native women at 16%, Asian or Pacific Islander at 20%, Hispanic at 19%, but in general, all races and origins, we are at 22%. So roughly around that number. So some signs and symptoms that people tend to experience. So we have the classic symptoms, which is chest pain, pressure, squeezing sensation. Some may experience some radiation to the neck, to the left shoulder, to the jaw. Sometimes it's palpitations, shortness of breath, or dizziness. However, those tend to be the classic signs and symptoms that not everyone experiences. Women tend to report milder symptoms. And for women, it tends to be more fatigue, weakness, nausea, some type of discomfort. And oftentimes we women will tend to kind of brush it off and explain it away and not necessarily take it seriously. And those are not necessarily the classic signs of cardiovascular disease, but it can still be alarming. I also wanted to mention that there are some differences in premenopausal and postmenopausal status of some women. Sometimes in premenopausal women who have had their ovaries removed, that can also increase their risk of coronary artery disease. Now, let's talk about some things for prevention and treatment. How do we prevent this from happening? Just as we talked about the risk factors and lifestyle, a lot of focus will be on the modifiable risk factors. And so stopping smoking will be one of the top things that we would like to encourage. Smoking can remove about 10 years of a person's life, and smoking cessation is up to 90% likely to return that 10-year loss back. And so stopping smoking is one of the major things that can help. Losing weight is the best way to lower the blood pressure. So about each kilo loss, or about 2 pounds, helps reduce the blood pressure by 1 point. So to bring your blood pressure from 140 to 120 would require about a 40-pound loss. Women who want to lose weight are encouraged to have 60 to 90 minutes of moderate intensity physical activity every day. And in general, women should exercise for a 150 minutes per week of moderate exercise, or 75 minutes per week of vigorous exercise. And moderate to vigorous will be where you can barely keep up with the conversation. We also talk about the good cholesterol and the bad cholesterol. The good cholesterol is the HDL, and that one comes from avocados, exercise. It comes from omega-3. Ideally, when you come into the clinic and your HDL is checked, the number ideally that we would like to see is greater than 50 in women. And the HDL is considered good because it transports fat from the walls of the blood vessel that cause the plaques in the arteries. It transports some of that fat to the liver to be processed. The LDL is the bad cholesterol. That's the cholesterol that sticks to the walls of the artery. Comes from bacon, comes from egg yolk. Ideally, when we check that number, it should be less than 130, ideally at 110. And the total cholesterol about 200. But at the same time, I always mention that those are numbers. We always look at the big picture, look at blood pressure, look at weight, and not just the cholesterol. Now, sometimes medications are recommended when these lifestyle changes are not enough. Sometimes aspirin helps platelets not stick. It can be associated with a bleeding risk, and so it is encouraged that patients that want to start preventative measures with aspirin discuss it with their doctor so that they can weigh the risk and benefits. There are some blood pressure medications to decrease the pressure that the heart has to fight. There are some blood thinners that can be added after a heart attack to help platelets not stick and create that plaque. And some statins can help also lower the cholesterol. Sometimes we talk about PCI, or percutaneous intervention, or angioplasty, and that is after a heart attack when a stent or a tube is placed in the coronary artery to facilitate blood flow. Now, the DASH diet, or the dietary approach to stop hypertension, focuses a lot on eating less sodium. It's one of the diets that have been well studied, that has a lot of very good evidence to help lower blood pressure and lower the LDL. So if you are the type of person who is known to have high blood pressure and have cholesterol issues, this would be a great way to help you focus on these two things. And so the DASH diet involves eating about 4 to 5 servings of fruits and vegetables every day, 6 to 8 servings of grains, about 6 servings of protein, 4 to 5 servings of nuts, and 2 to 3 servings of dairy. And focusing on salt and limiting salt is also another really great way to help lower blood pressure. The recommended sodium amount for the average person is about 1,500 milligrams, which is roughly half a tablespoon per day. And a lot of things that contain salt tend to be the things that we eat the most. Things like bread, rolls. A lot of the deli meats tend to be very full with salt, things like pizza, sandwiches. So being very health conscious when we're making choices about foods that we eat, thinking about the amount of salt that is contained in our foods is a very, very good idea. So just to give an example, a slice of pizza may contain up to 800 milligrams of salt. A bagel contains about 490. And so if 1,500 is the limit, a bagel would be roughly almost a third of the daily recommended amount, as opposed to a baked fish, which contains about 115 milligrams, or an apple that contains about 2 milligrams. And lastly, I wanted to mention that sometimes we focus also on adding salt to our diet. And it's not so much the fact that we're not adding salt when we're cooking. It's usually the processed foods that we use. It's the canned foods that we buy that tend to contain the sodium. So focusing on reading the little nutrition facts at the back and the labels will be very helpful. All right. And now I will leave it back to Debbie.
Thank you so much, Dr. Neal. We appreciate that presentation. A lot of great information as we think about that cardiovascular health. Got some questions for sure, but we'll hold those until the end of the presentation. Thanks so much. We'll be right back with you. Our next presenter is Dr. Sheree Caleb, a California native. She attended Oakwood University in Huntsville, Alabama, where she majored in biology. She went on to complete her medical degree at Loma Linda, and after medical school, she completed a residency in internal medicine. She now lives in Maryland and practices as a primary care physician for the Mid-Atlantic Permanente Medical Group in Washington, D.C. She's married and has 3 daughters, and she enjoys spending time with her family, traveling, and singing. Dr. Caleb, thank you so much for being with us today. We are so glad to have you here to talk to us about women's health and cancer, and we're looking forward to your presentation.
Thank you so much, Debbie. I'm so honored to be a part of this panel today. So we're just going to jump right in. I'll be covering breast cancer and cervical cancer. So we'll start with some statistics. So in 2021, breast cancer actually became the most common cancer in the world. And it's actually the second most commonly diagnosed cancer in women in the United States, with over 200,000 cases per year. This means that about 1 in 8 women in the United States will develop breast cancer in their lifetime, and that's about 13%. It's usually diagnosed in middle-aged and older women, with the median age of diagnosis at the time of diagnosis being around 62. So let's talk about some of the risk factors. Of course, we know that both men and women can be diagnosed with breast cancer, but being female does increase one's risk. Advanced age, having a family history of breast cancer and a first-degree relative, usually a mom or a sister. However, about 85% of breast cancers occur in women who have no family history of breast cancer. Certain gene mutations, more commonly the BRCA1 and 2 gene mutations, carry a higher risk of developing breast cancer. Other risk factors include exposure to radiation, starting your period before the age of 12, beginning menopause later in life, having your first child after the age of 30, never being pregnant, or hormone therapy, which includes progesterone and estrogen. And these are commonly found in oral contraceptive medications or birth control pills. And in postmenopausal women, they are often treated with these hormones to help minimize their symptoms. Obesity, medically defined as a body mass index of 30 or greater, is also a risk factor. Alcohol consumption and race does also play a big role. We know that breast cancer is more common in Black women as compared to white women. In fact, Black women have the highest rate of death from breast cancer. Black women are also more likely to be diagnosed with breast cancer before the age of 40. The risk is lower for Asian, Hispanic, and Native American women. Not all of these risk factors are modifiable, but some of them are. And so, things like obesity and alcohol consumption and things like that are things that we would want to try to avoid. We may be already familiar with some of the symptoms of breast cancer, but some of them you may not have heard of, so we'll just go through. Mass in the breast or armpit, enlarged lymph node in the armpit, change in the size, shape, or appearance of a breast, redness or pitting of the skin over the breast, kind of like that of an orange. And you'll see some examples in the pictures to the right. a newly inverted or retracted nipple discharge, which is usually clear or bloody, peeling, scaling, crusting, or flaking of the areola or the breast skin. And the areola is the dark area immediately surrounding the nipple. We'll talk about some screening methods. Of course, there's no single test that can detect all breast cancers. We have to use a combination of screening measures to increase the odds of early detection. So the self-breast exam is something that is advised, but not in isolation. Also, it's important to get physical exams by your doctor, mammography, ultrasound, and our breast MRI when indicated, and then genetic testing also when indicated. We'll start by talking a little bit about the self-breast exam. So you should try to perform it at least once a month. It's best to do a few days after your period in menstruating women. If you're postmenopausal, you can do it any time of the month. You might want to try to select one day and just stick to the same day each month. So you'll start the breast exam by standing naked in the mirror. And you want to place the hands on your hips and just observe for the symptoms that we discussed earlier, noting whether there's any changes in size, any lumps, any redness, scaling, peeling, dimpling, puckering, bulging. You may also want to press on the nipple and squeeze it to identify whether there's any discharge. You should also do this with the arms raised. Next, you want to lay down and raise your arm behind your head and then use the opposite hand to examine each breast. So if you're examining the left breast, you want to put the left hand behind your head and then use your right hand to examine that breast. You want to use the pads of the first few fingers to press firmly down on the breast tissue and move in a circular motion. And then you want to repeat that movement, that motion, moving down, across, up, across, down, across, up, across. And you start in the center of your chest nearest the sternum here, and then move towards the underarm. You also want to palpate up into the underarm as some breast lumps can occur there. You want to do this in a position where you're laying down and then also in a standing position. And if you ever find any worrisome or new changes to your breasts, you should call your healthcare provider so that they can schedule you for an exam in the office. We also have to remember that the breast self-exam alone is not sufficient for breast cancer screening, and it does not lower one's risk of dying from breast cancer. I did want to show a brief video. All right, so I wanted to also show this slide These are not breasts, these are lemons, obviously, but I thought it was a really nice picture that showed some of the abnormalities that you want to watch out for when you're doing your breast exams at home. So you want to look out for a mass, indentation or bulging of the skin, skin erosion, any increased redness or warmth, new nipple discharge, usually bloody or clear, dimpling of the skin, bumps or lumps, retracted or inverted nipples, new shape or size, or orange peel skin. And normal breast tissue can feel somewhat lumpy and sponge-like, so it can be difficult to know when you're feeling something abnormal. This is why it's important to become familiar with your own breasts so that you can detect when there's been a change. A breast lump usually will feel like something that's hard and more noticeably solid than the rest of your breast tissue. So another form of screening that we're all probably more familiar with is mammograms. So a mammogram is an X-ray of the breast. And for women at an average risk of breast cancer, mammograms are usually started at age 40 and continue to age 74. And they're usually repeated every 1 to 2 years, depending on the findings. What can you expect during your mammogram? So you'll be standing or sitting in front of the X-ray machine. The tech will place your breast on a plastic plate. And then another plate will firmly press your breast from above, flattening the breast. And then several pictures will be taken, and then this will be repeated on the opposite breast. And some women will experience some discomfort with this exam. Another form of breast imaging is the breast ultrasound, and that's mostly done to clarify a problem that's found on exam or during mammogram. And this is more commonly used in women with dense breast tissue. Breast MRI is used along with mammogram to screen women who are at an increased risk for breast cancer. Finally, genetic testing. Experts have come up with guidelines surrounding who should be tested. And there is some controversy surrounding it, but it's been decided that genetic testing may be considered in the following populations. So women who've already been diagnosed, those who have a known family history of a gene mutation, such as the BRCA mutation, a family history of breast cancer at a younger age, more than one family member who's been diagnosed with breast cancer, or a male family member who's been diagnosed, and those who have a personal or family history of either ovarian or pancreatic cancer also. So once you have an abnormal breast exam or an abnormal finding on an imaging study, you usually have to move to a breast biopsy to confirm a diagnosis. And this is a procedure that removes a sample of breast tissue. There are several different types of breast biopsies that can be done: fine needle aspiration or core needle, stereotactic biopsy, which you'll see a picture of to the right, ultrasound guided biopsy, and there's a picture there, or surgical. And surgical biopsies are typically done in the operating room, where they'll remove either a portion of the breast tissue or all of the breast tissue. Once you receive a diagnosis, you'll usually go through a staging process, and that measures the extent of disease. And based on the stage, then you can discuss with your provider what treatment options are best for you. And some of those treatment options would include surgery, which is an operation to cut out the cancer cells, chemotherapy, which shrinks or kills the cancer cells, hormonal therapy, which blocks cancer cells from getting the hormones that they need to grow, immunotherapy, which helps your immune system to fight against the cancer cells, or radiation therapy, which uses high energy rays to kill cancer cells. The good news is that advances in technology have helped the breast cancer mortality rate to significantly drop since the 1980s. And so currently the overall 5-year relative survival rate is about 90%. This means that 90% of women who are diagnosed with breast cancer at an early stage will still be alive 5 years later. And then the 10-year relative survival risk is about 84%. And again, this is for women who are diagnosed at an early stage. Currently, there are more than 3.8 million breast cancer survivors in the United States. So we'll move on to talk about cervical cancer next. We'll first begin with what is cervical cancer, or where is our cervix? The cervix is located where the vagina meets the uterus. So you'll see a picture of it here. And then To the right, you'll see the cervix as it's visualized through the vagina. And you'll notice it kind of looks like a donut. Here are some other examples. So on the left-hand side, you'll see pictures of a normal cervix. And then as we move to the right, you'll see early stage cervical cancer and then the more advanced stages. Again, the image on the right shows the cervix being imaged through the vagina. And so the top left corner of this picture shows a normal cervix, and then the lower left corner will show some abnormal cell growth. And then pictures to the right are showing cancer cells. Cervical cancer was once one of the most common cancers, one of the most common causes of cancer death for women in the United States. Currently, there are about 14,000 new cases annually, and it's most frequently diagnosed between the ages of 35 and 44. The average age at diagnosis is about 50. It's more prevalent among Hispanic Americans and non-Hispanic Black Americans. And human papillomavirus, also known as HPV, is detected in about 99.7%. So what is human papillomavirus, also known as HPV? It's the most common sexually transmitted infection in the United States. There are many different types, some of which may cause genital warts and/or cancer. It's usually spread through vaginal, anal, or oral sex. Some who become infected may clear the infection, and others will not. Those who do not clear the infection may start to develop symptoms many years later. Hpv vaccines have become available to help prevent some of these negative health effects. And you may have heard of this vaccine. It's called Gardasil. It's most effective if given before exposure to the virus. And so the CDC currently recommends all boys and girls receive this vaccine starting at ages 11 and 12 through 26. And it works like any other vaccine to help the body generate antibodies against the virus. So if and when the body is exposed to the virus, it will already have built up immunity against it. Risk factors, there are HPV related and non-HPV related. So the HPV related risk factors include early onset of sexual activity, multiple sex partners, high risk sexual partners, meaning if you have a sexual partner who is also engaging in sexual practices with others, history of sexually transmitted infections, and a weakened immune system. The non-HPV related risk factors include low socioeconomic status, use of oral contraceptive medication or birth control pills, cigarette smoking, and family history. Many women who are diagnosed with cervical cancer won't have any symptoms, but for those who do, the more common symptoms are irregular or heavy vaginal bleeding, bleeding after sex, vaginal discharge that may be watery, mucus-like, or pus-like and foul-smelling. Of course, these symptoms are fairly nonspecific, meaning they can be present in other disorders. So that's why it's important to just always speak with your healthcare provider if any of these symptoms arise inappropriately, and they can do the necessary workup and get to a proper diagnosis. So the death rates of cervical cancer have significantly dropped due to screening, and we use the Pap Smear to screen. It starts usually at age 21 and is repeated every 3 years until the age of 29. And at age 30, we initiate routine HPV testing along with the Pap Smear. And then you no longer need to receive your Pap Smears every 3 years. It can be every 5 years. However, if you do have an irregular or abnormal Pap Smear, then your healthcare provider may order additional testing, and then your interval of testing may need to change. To the left, you'll see a picture of how the Pap Smear is completed. So you're usually laying on your back in the office with your feet in stirrups, legs spread apart. The speculum is inserted through the vagina and opened slightly to visualize the cervix, and then a brush is used to collect some cells from the middle of the cervix. And in this picture, you'll see the cervix as visualized again through the vagina, and the examiner is holding an instrument to collect cells from the center of the cervix, which will be studied under a microscope for changes, abnormal changes. Once we see anything abnormal on a Pap Smear, the doctor may recommend a colposcopy. So a colposcopy is a procedure to closely examine the cervix, vagina, and the vulva. And your doctor will apply some acetic acid to the area, and they'll be able to directly visualize any abnormal cells. From there, they may recommend further testing, including biopsy and removal of those abnormal cells. So one procedure is known as LEAP. And LEAP stands for Loop Electrosurgical Excision Procedure. This is where we use a fine wire loop to remove tissue from the cervix, and it looks kind of like a loop, as you'll notice there. Another procedure that can be done to remove abnormal cells from the cervix is called a cone biopsy. Again, once you've received a diagnosis, you have to go through a staging process. So the staging will again determine what type of treatment you're eligible to receive. And treatments for cervical cancer include surgery, chemotherapy, radiation, and immunotherapy. So again, good news is that the rate of death due to cervical cancer has decreased. And currently the 5-year survival rate for all people with cervical cancer is about 66%. Of course, survival rates can vary based on factors such as race, ethnicity, and age. Thank you.
Thank you so much, Dr. Caleb. We really appreciate your presentation, the good information about cancer. And I'd like to invite all of our panelists back. If we can get everyone back on screen, we've got some questions we'd like to address to you all. And the first question that I'm going to just put out there, is we're still missing one other person to join us, Ms. LeGrand. Okay. Yeah, thank you. Good to have you back, Ms. LeGrand. One of the first questions that I have would be, Ms. LeGrand, you brought up, when we were talking about multiple sclerosis, you brought up early in your presentation, you talked a little bit about inflammation and that it did play a role with multiple sclerosis. I've also heard a lot about inflammation as it relates to our cardiovascular health and also cancer. So I'm wondering if each of you could just talk a little bit about inflammation and what we should know and how it impacts our health. And we can start with Ms. LeGrand.
Sure. So when we're talking about MS, we're really just talking about how MS is an autoimmune disorder. And so it's more specifically, it deals more so with the spinal cord and the brain. So there is some inflammation, but for the most part, we're looking at how the immune system basically malfunctions and destroys the fatty substance that coats and protects the nerve fibers of the brain and the spinal cord, which is the myelin. So it's more so around that area. And also, we're looking at how there's damage to the protective covering and also to the nerves that disrupts the flow of nerve impulses in the body. And so, as mentioned before, as a result of that, the messages from the brain and the spinal cord going to other parts of the body may be delayed and have trouble reaching their destination, which is what causes a lot of the MS symptoms.
Dr. Mio, anything about inflammation that we should be thinking about as it relates to our cardiovascular health? Dr. Mio, your mic is mute. Just one moment, please.
Oh, sorry.
Okay, now go ahead. Thank you.
Yes. So like I mentioned earlier, inflammation, especially autoimmune diseases, we're seeing more and more of that as one of the newer emergent risk factors for developing cardiovascular disease. And one of the best ways I've explained inflammation is when the body is interacting with the environment, sometimes just like when you have a house and the lights are turned on, imagine inflammation as all the lights being turned on and the body's not able to successfully turn them off after it's done what it needed to do. And when the lights remain on, there's a lot of processes at play that can affect the different vessels and especially the coronary arteries, where a lot of the byproducts of inflammation sit in the blood vessels and create plaque. And plaque is essentially the end product of a lot of different things that causes blockage in the vessels. And once we have blockage, that's when we have cardiovascular disease. And so, in a sense, that's how inflammation can lead to heart attacks. It can lead to a dysfunction of the heart, and it plays a major role into developing this disease.
Okay, great. Thank you. Dr. Caleb, inflammation and cancer, any connections there, anything we should know?
I really like the way Dr. Mio put it about the lights in the house being on. Inflammation is often the body's way of trying to protect itself against disease. And in the process, it ends up creating a lot of pain and worsening or propagating more inflammation. And that, of course, can become destructive. It causes a lot of symptoms and it worsens the condition. With breast cancer specifically, there are different types of breast cancer, which we didn't really get into during the presentation, inflammatory breast cancer being one of them. And the rates of, so depending on the different types of breast cancer that there are and what you're diagnosed with, that may worsen your prognosis and your the types of treatment that you can receive may be more limited based on certain types of breast cancer, including the inflammatory types. So
we do have a question in the chat from Sarah, who's asking us about how can our diet make a difference? And I'm sure that each one of you could talk to us quite a bit about it, but can you just give us just a brief from each of your perspective? What are you seeing in your practice and your work with diet? What the latest research? I know that's a big question, but you can just give a little tidbit about how diet impacts each one of your areas. And again, I'll start with Ms. LeGrand.
Sure. So when we look at diet and nutrition around MS, it's more so for whole body health. So there isn't a specific diet that's the cure-all for MS, for example. Again, it's not, MS is not something that's contagious. And it's treated with disease modifying therapies. So when we talk about nutrition, we're really talking about just staying healthy overall. So whole body health, because apart from living with a chronic condition, you do have other parts of your body that need care. And as both experts mentioned earlier, when we talk about cardiovascular health, when we talk about breast cancer, it's all about diet. So you're not just living with MS. There may be other parts of your body that you need to treat as well. So when we're talking about nutrition, it's really to develop and live a healthy lifestyle, to eat healthy, to exercise, and not necessarily as a way to cure MS, for example.
Thank you. Dr. Mio?
I actually want to piggyback on that too. A lot of it is prevention. And so diet and lifestyle is the major way to prevent cardiovascular disease. We talked about the low sodium diet. We talked about the DASH diet. There's also the Mediterranean diet. All these things are different ways that we can prevent cardiovascular disease. Exercise is also very, very important. It helps increase the good cholesterol, like we talked about, and lower the bad cholesterol. And so those two things go hand in hand. And I always talk about, looking at the whole body also, just like Ms. LeGrand mentioned. The body is connected to itself. And so you focus on one part, the other parts will come along as well. And so eating those types of foods, we talk about low sodium, we talk about nutrient rich foods, avoiding processed foods. All these things play a major role into preventing disease.
Thank you. Dr. Caleb?
Sure. So again, I agree with what our other expert panelists have said. It has a lot to do with diet and lifestyle behaviors. So, you can, science tells us now, and we're much more aware than we were prior, that there are certain foods that cause inflammation, and then there are other types of foods that can actually help us fight against inflammation. Some of the more common ones that cause inflammation are like the processed foods and red meats, fried foods, refined sugars. And then fat like shortening, margarine, things that actually help us to fight against inflammation are things like vegetables, nuts, whole grains, healthy fats that can be found in meats like fish, and fruits. Those would be some examples.
We have, I've got another, thank you so much. We have another question in the chat that what should women in their early 20s and 30s be thinking about as it relates to health? So for those of us that are a little past 20s and 30s, we've had to give some more thought to that. But for women in their 20s and 30s, what should they be focusing on? What should be their number one concern? And I'll start, Dr. Caleb again. If you could just give us what you think for young women, what should they be focusing on?
Again, I would say lifestyle, so diet, physical activity, and preventative care. So making sure that you're seeing your doctor annually for your exams, that you're getting any screening exams. For young women specifically, that would include usually the Pap smear is the main thing that I screen for women in their 20s and 30s, and blood tests, and then mammograms if it's indicated. But typically that doesn't start until age 40 unless there are risk factors that are present in one's 20s and 30s.
Dr. Mayo?
And again, lifestyle. I want to say that the 20s and 30s it's a very crucial time because that's when a lot of young adults are forming their habits that are going to be lifelong. If they're deciding to abandon some habits that they grew up with and they want to formulate their own style. And so I think it's a very crucial time for young women in their 20s and 30s to pick up a lot of really good habits. Exercising, eating all the right foods should start at least by then, and it helps prevent a lot of these lifelong chronic illnesses.
Okay, thank you. Ms. LeGrand, any thoughts? Anything to
Yeah,
add?
yes, absolutely. So because MS is a young person's disease and mostly diagnosed in women, it is important to make sure that you are seeing an MS specialist, so someone a neurologist who specializes in MS, that can put you on the correct disease-modifying therapy, so the correct treatment to help manage your MS. And then, as both experts mentioned earlier, it's important to look at the whole body health. So make sure that you are eating a healthy, well-balanced meal, and you're exercising, and you're managing your stress, because stress can also is a factor in MS as well, and it can also be it is also a symptom of MS. So it's important to manage your stress and to discuss these different issues with your loved ones.
Okay, thank you. Continuing with you, Ms. LeGrand, you had mentioned in your presentation as a part of the prevention for MS that there's something about a vitamin B deficiency. I just want to follow up on that. I think you said a vitamin B deficiency. And also Sarah in our chat has asked us a question about over-the-counter supplements. My mom was a huge supplement user, and I'm kind of dubious about it, but I'd love to have all three of your opinions on over-the-counter supplements as it relates to each one of your specific areas. And I'll continue with you, Ms. LeGrand.
Sure. So there has been some research that shows that there is a vitamin D deficiency among those living with MS.
Vitamin D, you said? I hate to interrupt, but vitamin D.
Yeah, D as in
Okay.
David. Yes.
Thank
So
you.
vitamin D.
Okay.
And during that research, they noticed one of the reasons why it was originally thought to be a white person's disease is because of the levels of where the research originated from, so from the northern European parts. And so they noticed that there was a lack of vitamin D. And so that was attributed as one of the possible causes of MS. Now, we don't know for a fact what actually causes MS, but those are just one of the things that researchers noticed was a vitamin D deficiency. And so it's not necessarily used as a way to prevent MS, but I know there are some healthcare providers who do recommend vitamin D as a supplement to people living with MS. And that is something that an individual would have to sit and discuss with their MS specialist to determine if, in fact, it's something that they do need and if it's a necessity for them. Because again, MS is different from person to person. So one person's MS is not necessarily the other. So this is something that you would have to sit and have a discussion with your healthcare provider. And that includes any and all other supplements that someone decides to take.
Okay. Dr. Mio, your thoughts on supplements?
That was a very good explanation that Ms. LeGrand gave, and I completely agree. I think that if supplements are being considered, it should be based on and it should be on an individual basis, discussing with your doctor, your provider. Just because a lot of times supplements may not necessarily have this large body of evidence behind them, but individuals may still find some either relief or some help with supplements. Now, that said, supplements in and of themselves may not necessarily cure or prevent. I still say we need to take a look at the whole picture. And the whole picture will definitely include things like lifestyle, smoking cessation, and all these things that we talked about earlier. If we're not doing those and focusing only on the supplements, I think we're doing ourselves a disservice.
Okay. Thank you. Dr. Caleb?
I would just say that I agree. And I don't know if I have a whole lot to add, but because I didn't focus my research much on vitamin deficiencies as it relates to breast cancer, I know that there is some suggestion that perhaps certain vitamin deficiencies might slightly increase one's risk, but the risk of that being a cause for breast cancer is really not well documented to my knowledge. So when patients ask me about taking supplements, I usually, I try to look it up and see, because I'm not familiar with all of them. I try to see what the active ingredients are and if they would interact with any of their other medications negatively. And if they feel comfortable moving forward to taking it, then that's fine. Multivitamins usually I think are pretty safe to take. And if we do identify any vitamin deficiencies in blood work, then I usually will recommend over-the-counter supplements.
Okay. Thank you. One of the things that seemed to have come up a number of times were that Black women were more at risk for a number of these conditions than the general population. And I'm wondering if either any of you have any thoughts on why that would be. And then as a follow-up to that, I'm thinking about how important do you think it is for Black women specifically, as we're talking about women's health, for us to find healthcare professionals that are also Black women? And if that's not possible, what can we do to kind of take care of ourselves and advocate for ourselves? So it's kind of a three-part question, which would just be why are Black women more at risk? Any thoughts on that? And how important is it for us to have healthcare professionals that look like us? I'll start with Dr. Mio.
So there's a number of different theories as to why, especially African Americans, tend to be more affected by certain diseases. And I think our first panelist, Ms. LeGrand, actually addressed quite a lot of that. A lot of it has to do with disparities that a lot of African Americans experience when they're interacting with healthcare providers in the healthcare system. We have things like access, like quality of the care. There's some environmental or different influences that affect the way the children grow up, how young adults enter the workplace that can affect their health. We have racial discrimination. There's different things like diet, different things like smoking. There's socioeconomic factors. All these things play a significant role. And I think that is one of the better theories as to why African Americans seem to be a little bit more affected. There's also things like cultural aspects, like the foods that we eat, especially we like our Southern foods. And so that in itself is a big thing that can affect the heart and the vessels. So I think that's probably one of the better answers to that question.
Okay.
I don't know what everyone else thinks.
Yes. Dr. Caleb, Any thoughts or?
I totally agree with everything
Okay.
she said. And then I would just add, lack of education and exposure, because in our community, it's just not really certain things are not talked about enough. And there's just, maybe they're not talked about because people just don't know better. And because there aren't a lot of us in the healthcare field. I do have a lot of my patients find me because I'm not, Black women, primary care providers are not very common. So, having a healthcare provider who looks like you and can understand you culturally does help with breaking that barrier. But also, if you're not able to identify someone who looks like you, um, it's still fine. I mean, you can still find really good healthcare providers, I believe. You might have to shift around a little bit until you find someone who you get along with and who works well with you and can explain things in a way you understand and is sensitive to your concerns. So I wouldn't give up if you feel like you haven't found the provider that's best for you or that looks like you. Keep looking and trying your best to communicate effectively with your healthcare providers. And yeah, that's it.
Okay, thanks. We do have we have a question in the chat from Anid who's asking if there are any treatment for MS. And I know that we went over that earlier with Ms. Legrand. There are a number of treatments. Is there anything you can just say briefly to Anid, Ms. Legrand, just about treatments for MS? Just a couple quick bullet points. I know you went over it in detail earlier, but anything you want to say, what's your top treatment for MS?
Well, I can't say there's a top 3 or a top 10.
Okay.
And that's again because MS varies from person to person. So one person may experience a variety of symptoms that is going to be completely different from someone else. And then when you add in genetic factors, then there's other things that you're adding to that. And so I would say the best thing to do is to talk to your healthcare provider, your MS specialist, to determine which treatment will be best for you.
Okay. We've got another question about representation. I know we're just about out of time here, so I'll just be real quick. As you mentioned, it's difficult to find a woman of color in various medical fields. And so we just are curious as to what drove you to choose your profession. And again, I'm not looking for the whole story, but just if you can give us a brief answer of why you chose the field you're studying. And I'll start with Ms. Legrand.
Well, for me, my passion has always been in healthcare and medicine, and I especially love the field of public health. I feel like when we look at a lot of conditions, we're looking at it more so in my field from the perspective of the public and how certain conditions affect groups of people overall and not just one person. And so that's something that I've always been interested in overall and have always enjoyed working in. And then specifically the area of MS, because it's such a mysterious disease, even still to this day. We're talking about the early 1300s when the first case was found, and we're still trying to determine the causes of MS. So honestly, it all boils down to fascination and passion.
Okay, thank you. Dr. Mio?
I want to say for me, it was probably my mom. I grew up with my mom working in the hospital, seeing patients, and I used to see her answering questions, sometimes outside of church, sometimes outside the supermarket. People would walk up to her and ask her questions. She was always very helpful. And so for me, that was part of my upbringing. And so kind of watching that and wanting to share that myself, I think kind of played a role, I want to say.
Okay, thank you. Dr. Caleb?
I would say that the study of biology and physical and the biological sciences just always really intrigued me. And so, like starting in high school, I just knew that's what I wanted to focus my studies on in college. And then going into medicine from there, to me, seemed like a natural progression because I wanted to work with people and I wanted to help people just know about their bodies and about how to prevent diseases, how to treat existing conditions, and educate people on how to live more healthy lives.
Great, thank you. Okay, 2 more questions, and then we're going to give all 3 of you an opportunity to wrap up. How can someone nicely tell a provider they're not fitting your need and ask for a recommendation to another provider? Any one of you want to tackle that question? So you're just not working for me. Do you have any thoughts about that? Any one of you?
Um, so I would say, if someone isn't working for you, you can I mean, I don't know too many nice ways to put it, but, basically this relationship is not working out. Or I would like to get a second opinion. That's also another way to say it. And everyone has a right to, because after all, this is your body, and you are your best advocate. So if you don't feel as though you're getting the care that you deserve, you can always ask for another opinion, or if there's perhaps another healthcare provider that you can work with.
Any other
I
thoughts?
would I would say it kind of depends on the organization that you're receiving care from. So, in my practice, if a patient doesn't prefer me, they don't have to say it. They can just move to a different provider. Um, but I think there is a nice way to just say, hey, this is kind of what I was expecting and looking for in a provider, and I don't feel like I'm receiving that. And sometimes as a provider, that is helpful information because I might not be communicating effectively for that individual patient. And I may realize I need to change my approach. And so sometimes I have done that, and then it helps the relationship to take a different turn, and we get along just great, and they feel like we're partnering, and I'm answering their questions appropriately, or I'm fulfilling the expectations. Because often we as providers, we have certain expectations that are different from our patients' expectations, and it's only when both parties' expectations are met that there's fulfillment and satisfaction, and patients feel like they're being heard.
Okay, thank you. Thank you all so much. We're gonna give each one of you just a couple of minutes to just give some final thoughts. And one of the things I'd like each one of you to do in your final thoughts is to give me just that one thing. Like if you can just tell me one thing that you want me to remember or to do. There seems to be so much information that's out there in terms of diet and exercise and what we should or should not do and what medications and supplements and exercise. But if you want to leave me with just one thing that's going to stick in my small brain, what would that be as you give us your wrap up for today? And I'll start with Ms. Legrand. Thank you.
Thank you. I would say staying positive. Because regardless of the chronic condition you're living with, it's important to stay positive through it all and seek help when you need it.
Okay, thank you. Dr. Mio.
For me, I want to say be aware of what you buy at the grocery store. So every time you walk by the grocery store, you pick up something, read the back, see what's there. There's a lot of salt and a lot of added ingredients and a lot of foods, a lot of things are processed. And I know that we talked about it in our health disparities conversation, that, not everyone has access to certain foods, but whenever you're at the grocery store, you pick up something, flip it, look at it in the back, see what's in it. If there's too much sodium, think twice about it.
Okay, thank you. Dr. Caleb?
I would say just do your best to be educated. If you don't know, try to find resources that can help you get the information that you need, and or speak with your healthcare providers so that they can kind of lead you to those resources, because lack of knowledge is failing us in a lot of areas.
Great. Oh, ladies, thank you so much for your presentations today. We have had a lot of great information, and I, for one, have feel like it's been very helpful. So we thank you so much for being a part of that today, and we thank all of our viewers today for being a part of this and for listening. It's important that we care for the bodies that God has given us, and God has provided opportunities for us to learn and to have the information and the knowledge. And so my prayer for you all is that we will have the strength to do what we know we should be doing, and that we have wonderful, talented health providers as are exemplified today to assist us in that journey. So thank you so much, ladies, for all being here with us today. And we hope you viewers will be with us again in May as we continue our health series. And we'll be talking about trauma in May, coping with it while protecting your heart, how to survive trauma, and to but to thrive in spite of it. We've all experienced trauma quite a bit these last 2 years with COVID, whether you've had it yourself or known someone who's had it. We've been infected by it. We've all been affected by indirect trauma as we listen to the news and hearing people that have been sick and have passed away. And now with this war in Ukraine and with Russia, there's more indirect trauma that we're all going through. So we look forward to discussing with you again in May more about trauma. And so please join us. Most of all, we pray that God will be with you as we continue to explore ways to take care of our health. Thank you so much for being with us. We'll see you again in May.